So, in talking about the complications, I need to explain about refeeding syndrome. Have you heard of refeeding syndrome before? Okay. So, refeeding syndrome is a potentially very dangerous complication in eating disorders, especially in someone who has been malnourished for a long period of time, and all of a sudden they begin to eat. So, someone who's been starving, and then you begin to provide food, a lot of food at once, that person is at risk of developing refeeding syndrome. So the way to understand it is that, think about our body being made up of different cells, and the cells, they function when you provide food for them, right? They function by building energy, right? They build energy units. We call them ATPs, adenosine triphosphate. Those are the energy units that we need to do everything that we do. But you cannot build them if you don't have food. Okay? So, the main ingredient of ATP is phosphate. If I'm eating okay, I'm using my phosphate to build energy, and I'm fine. Okay? If I'm not eating, the energy is not available because food is not available in the cell. So the phosphates in my plasma, they're just flowing, right? They have nothing to do. The moment I begin to eat, and I begin to eat large amount of food, what happens? The phosphates in my plasma, they rush and enter into the cell. To do what? To work with the food and build energy. So, the individual develops hypophosphatemia, which is low phosphate. That's the hallmark of refeeding syndrome. Low phosphate. So that is why when we are refeeding them, we have to do it very slowly. We start slow, we go slow. And we use phosphate supplementation. So sodium phosphate, 500 milligrams twice a day, prevents refeeding syndrome. Make sense? Because if you don't do it, and somebody develops refeeding syndrome, it's a major problem. They have edemas, they have vital signs, instability, and a lot of cardiac problems. Do you have any questions about refeeding syndrome? Make sense? Okay. So because of all of those complications that we talked about, we need to make sure that when we are suspecting an eating disorder, we do a lot of investigations. The investigations usually should start from physical examination of the patient, a malnourished patient. What do you look for? So I want to look for things like signs of dehydration, dry skin. They're oftentimes very pale. They have what we call lanugo hair, like, you know what I'm talking about? Okay. Tooth erosion, blood pressure changes in their heart rate, especially, it's not just the absolute values of the heart rate or the blood pressure. What you are looking for is what we call postural drop. So from lying position to standing up. If you see a change in heart rate that is greater than 20 beats per minute, or a drop in blood pressure that is greater than 20 millimeters of mercury, you should be concerned. So of course, after physical examination, you want to do ECG, electrolytes, urea, creatinine, random glucose. For me, as a psychiatrist, I always want to focus on their mental state, because it's not about the numbers, right? Their electrolytes could be okay, their glucose could be okay, but if they tell me that they're suicidal and they have a plan, would I let them go? So you must ask questions about their mood, and you must do a suicide risk assessment. Because we know that these patients, oftentimes, they have comorbid conditions of major depressive disorder and anxiety disorders as well. So the principles of treatment, in essence, is about, we need to consider the safety of the patient, nutritional rehabilitation, medical stabilization, the psychological needs of the patient, and in some cases, we admit them against their will. And I will tell you in a few minutes, situations whereby you may want to consider involuntary admission. Okay, this is my second question. So you have a 15-year-old girl brought by her parents to the emergency room for severe weight loss. 30 pounds in the past 6 months and a BMI of 12. She's consuming less than 300 calories per day. More recently, she has been refusing to eat anything. Her weight is 30.5 kilograms. On examination, she's extremely pale and malnourished. Heart rate is 49, blood pressure is 88/52 millimeters of mercury, and her temperature is 35 degrees Celsius. EKG changes include T wave flattening and lengthening of the key T interval. What would be the best treatment? What would you do?
Admit her? Would you have to warm her up because her body temp is low, so that would affect the way her body systems are functioning?
Correct. What else would you do?
She needs to be admitted. I mean, she's kind of low in her weight, she's got lengthening of the QT, so there's cardiovascular issues going on.
Yes. A lot of things going on. Cardiovascular complications, right? Her blood pressure, is low, right? Heart rate is quite low. She's not eating. She's not eating at all. Her BMI is 12. Okay? She's refusing to eat. Her temperature is very, very low. Her QT is prolonged. Okay, so I have 4 options here, A, B, C, and D. If you think it is A, can you please show hands? PIPU is the psychiatric unit for adolescents in the hospital. If you think it is B, C,
What about A and B?
A and B. Okay, any other thoughts? If you think it is D, can you show hands? Okay, why D?
Because you can't just start her eating right away if she hasn't been eating at all. You have to control very specifically, tube feed, nutrients, put her on complete bed rest so she's not exerting any calories to break stuff down, all that kind of stuff.
Plus she's
And in a
15,
very controlled
she's,
setting.
Plus she's 15, so she needs to be on pediatrics.
Yeah. Yeah, all correct. So she needs to be admitted. The point I want to make is that what is more important initially is the medical stabilization. So you don't admit to psychiatry, right? You admit medically.
For her.
So, yes, for this particular case. Yeah, you admit, you stabilize her medically, you can involve the psychiatrist as well, you can involve the psych team as well. The medical stabilization is the first thing for her, and she needs NG feeding. Okay? Okay. Indications for admission. As I said earlier, you want to admit someone who is acutely suicidal, even if they are not medically compromised. If they come to me and they've made a major suicide attempt, or they have a definite plan, and all of their electrolytes are okay, and their weight is not terribly low, their BMI is not terribly low, I still want to admit them, right? If they are refusing to eat, like in that last question, you want to admit them. Medical complications of electrolyte imbalance and cardiac issues, you want to admit them. Vital signs, instability. Sometimes we admit them to interrupt symptoms, so someone who is purging like 20, 40 times a day, you want to admit so that they don't have the opportunity to do so. We admit if parents are not coping, or if you are worried about the home environment, or you've tried to treat them in the outpatient and you are not making any progress, or they have severe mental health conditions in addition to the eating disorder, so people with major depressive disorders, severe anxiety disorders, you may want to consider admission as well.
Would you admit as somebody who's acutely suicidal to 1 South or 4 North?
If they are acutely suicidal and they are eating, I will consider admitting them to 1 South. If they are not eating and they are suicidal, I can admit them to 4 North and have one-to-one person with them. Make sense?
I just had a question. So, like for that case that you just showed us, if she's 15 and she's being admitted involuntarily, would you still need to obtain consent from the parent for them to be admitted, or does like the Mental Health Act or whatever just veto what the parents say and then?
To be honest with you, it's a very, very gray area. I try to obtain consent from the patient, first of all, and I always obtain from the parents as well. I am not aware of any age cutoff, that, to say things like, okay, if they are 14, they can give their own consent, or if they are 15, they can give their own consent. I'm not aware of that, but I think it's good practice to seek consent, even if they're 10 years old, So when they say no, then you begin to think of involuntary admission.
What if the parents say no?
Yeah, if the parents say no and you are worried, like in that clinical scenario, the parents say no, I will use the Mental Health Act, and I will get the ministry involved as well. So I will phone MCFD and then I will complete Form 4, the pink form. The reason I'll be phoning MCFD is to cover my backside.
Because that would fall under neglect. And so that could facilitate a temporary removal and into ministry care until the child is stabilized, and then they sort through the family issues. But they're under the microscope by MCFD if they're refusing admission when it's life-threatening like that.
Yeah. So you can make a case.
And I would say most of the time, the parents, that's very rare to have that happen. Most of the time, the parents are very scared and upset, and they're relieved when we talk about admission.
Yeah. I think, yeah, you're right. It's not common. You know, we may have issues with the parents after the kid has been admitted.
Yes, we do. Yes, we do.
Yeah. Okay, so medical stabilization. Now it's quite easy. You know what we need to do is, go into the system and print out one of those orders. For children, we have the child version, and we have the adult version for adults as well. And it has everything that you need to do in terms of investigations, in terms of physical examinations. What you need to look out for is in the eating disorder protocol. Okay? So, like I said earlier, we need to pay special attention to potassium because of the association with cardiac abnormalities. We need to pay special attention to phosphate because of refeeding syndrome. Okay. I'm sure Mandy, our dietitian, will be talking more on this, the meal planning in the hospital, the scheduling of the meal portions, throughout the day, and the calorie calculations and things like that. What you need to know is that food is the medicine. So my slogan in our clinic, what I say to parents is that number 1 treatment is food, number 2 treatment is food, and number 3 treatment is food. That's what I say to them. Because I know that with increased food intake and weight restoration, all of those abnormalities, they disappear. Even their mood improves when they begin to eat. They become less anxious. They become less worried about their weight. So food is the medicine, but in order to achieve that, we need to build a very good therapeutic alliance with the patient and the families. We need to be gentle. We need to listen. We need to be empathic. Patients with anorexia nervosa are very smart, and they will play one staff against the other. We see it all the time. They split, okay, without wanting to. So you really have to be extremely gentle and make sure that information to the patient and to the family is coming from the team as a whole. The team will meet once a week, make decisions together, and provide feedback to the patient. Because if you go individually, it's splitting. Okay? So, in the inpatient unit, we aim for a weight gain of 2 to 3 pounds per week. What is important is as the patient becomes more compliant and they begin to gain weight, we have to reciprocate by allowing them some privileges. Okay, you do it slowly. You may allow them time on their phone, time to go for a walk around the corridor or go to the coffee shop. As weight gain increases, you increase the privileges. So, first of all, we need to know that the most important thing is nutritional rehabilitation. You cannot do psychotherapy when someone is malnourished. It doesn't work. Okay? Nutritional rehabilitation first, and then psychotherapy. And psychotherapy starts with psychoeducation for the patients and for their families. We build alliance, as I said earlier on, and certain psychotherapy types have evidence base more than others. Okay? And I know that Christy and Carla will be talking more about the psychological treatments, but I want to mention a few things. Okay? So for anorexia nervosa, there's very good evidence for FBT, family-based therapy. So essentially what it means is that you work with the patient and the families for about 1 year, approximately 1 year. It's divided into 3 stages. In the first stage, you provide education to the family. You generate a little bit of anxiety by, explaining to them all the possible complications as a result of starvation. You empower the parent to feed their children. That's the essence of stage 1. So the parents take control of feeding their little ones. In stage 2, the adolescents begin to take control of feeding. And in stage 3, you begin to address developmental issues. So as I said, this has a lot of evidence for anorexia nervosa. For bulimia nervosa, there's more evidence for CBT, cognitive behavior therapy. Okay? The aim is to decrease the frequency of binging and purging. So you ask them to keep food diaries. You ask them to write down triggers for binging, triggers for purging. It can also be used, CBT can also be used in anorexia nervosa, but the evidence is more in bulimia nervosa. Other therapies include DBT, dialectical behavior therapy, for bulimics, and IPT as well, interpersonal therapy. Now, I'd like to spend a few minutes to talk about medications, because we use them sometimes. What you need to remember is that for anorexia nervosa, no medication is approved by Health Canada. Having said that, we use medications. We use medications to treat comorbid conditions, because hardly will you see someone with an eating disorder without a comorbid condition. Oftentimes they fulfill criteria for generalized anxiety disorder, obsessive compulsive disorder, major depressive disorder. This is why we use SSRIs, selective serotonin reuptake inhibitors. So we can use things like fluoxetine, sertraline, escitalopram. In anorexics, we also use antipsychotics. Because if you think about it, it's almost like a delusional disorder, It's like psychosis. Someone who is BMI of 12 and who is telling you that this is how they see themselves when they stand in front of the mirror. And you can spend the next 3 hours trying to talk to them. It's difficult to change their mind. So I think that's why, in some cases, we use antipsychotic medication. And the commonest one that we use for anorexics is olanzapine. So olanzapine in small doses, about 2.5 milligram to 5 milligram at bedtime. What I found clinically is that it helps to decrease anxiety about body image. It helps to decrease anxiety about eating. prescribe olanzapine, you have to make sure that you monitor them for side effects. Okay? The story is a little bit different with bulimia nervosa. With bulimia nervosa, there's good evidence for use of SSRI. So something like fluoxetine, we know if you prescribe it, it decreases binging episodes. It decreases urge to purge. It's important that if you are using SSRIs for bulimia nervosa, you should aim at very high doses. So much higher than the doses you would typically use for major depression. So for major depression, you may find someone taking Prozac 20 milligrams, for instance. In bulimia nervosa, you go as high as 60, 80, 100 milligrams per day. Okay? Okay, so involuntary admission. When do we consider involuntary admission? We consider, I'm nearly done, just about 5 minutes, okay? Involuntary admission should be considered in situations whereby the patient is refusing to be admitted. The patient is refusing to be admitted, and they have a very low BMI of less than 13. They are not eating at home. They cannot stand from a sitting position without using their arms, to hold on to something because they are so weak. Or they cannot swallow because they are so weak. Or they are suicidal and they are refusing to be admitted. Those are the situations whereby you need to consider involuntary admission. Okay, so what's the outcome after treatment? As I said before, eating disorders are associated with very high morbidity and high mortality. For anorexia nervosa, up to 20%. And 1/5 of the deaths from anorexia nervosa is from suicide. So it's a very serious condition, very, very serious condition. The remaining is from medical complications. The prognosis is slightly better with bulimia nervosa. So, how many of them recover? Up to 50% of adolescents with anorexia nervosa will have full recovery in about 5 years. 25% intermediate recovery, and the remaining 25%, unfortunately, will become chronically sick. Better prognosis is associated with onset and treatment before age 15. And the reason for that is because there's shorter duration of illness. So if you see them, you identify them, you start treatment before age 15, the prognosis is better. If you treat within 3 years of the onset, the prognosis is better. If their weight is restored within 2 years of the disorder, the prognosis is better. Worst prognosis is associated with longer duration of illness, greater individual and family disturbance, and substance use disorders as well. Okay, thank you.